21% of American adults smoke, with a little higher percentage of men than women, 23.5% versus 17.9%. Whites smoke more than African Americans. African Americans smoke more than Hispanics, and Hispanics smoke more than Asian Americans. Smoking is the greatest single cause of preventable death. In the U.S., it accounts for 1 in 5 deaths, with the largest portion of these deaths being cardiovascular related. Smoking also accounts for at least 30% of all cancer deaths. Cigarette smokers appear to be less health conscious and are more likely to engage in other unhealthy behaviors than non-smokers. For example, alcohol consumption. 6% of high school students use smokeless tobacco. Smokeless tobacco use is most common in white males, sports figures as role models. There is an association with oral cancer and cardiovascular disease. Christopher Columbus found Indians smoking tobacco in pipes and as cigars. Cigarettes, however, were not popular until the 20th century. Because cigarette smoking was considered effeminate, it was not widespread. It wasn't socially acceptable for women either. It was acceptable for men and women to use snuff or ground tobacco. The widespread adoption of cigarette smoking was aided in 1913 with the development of the blended cigarette. Research linking smoking to lung cancer began appearing in medical journals as early as the 1920s, but the dangers didn't reach the public until 1952, when Reader's Digest published Cancer by the Carton. Still, smoking rates continued to rise. Between 1940 and 1964, consumption more than doubled to 4,500 cigarettes per adult per year. In 1964, the U.S. Surgeon General's report spelled out the adverse effects of smoking on health. No other single report has had this large of an effect on public health. In 1967, each cigarette package had to carry warning of the potential danger of smoking. In 1970, cigarette advertising was banned from TV and radio. In 1975, the military stopped including cigarettes in rations. In 1982, the federal excise tax was raised. In 1986, Surgeon General Koop issued a report on involuntary smoking, or secondhand smoke, which provided scientific basis for protecting non-smokers. In 1990, Congress banned smoking on domestic flights. In 1997, President Clinton banned smoking in most public buildings. In 1998, cigarette manufacturers finally acknowledged that smoking was addictive and caused cancer. In 2003, Mayor Bloomberg banned cigarettes in New York City restaurants and bars. By 1955, 53% of U.S. men were smoking. Women did not begin smoking in large numbers until the 1940s. Since 1965, both men and women have begun to smoke less, but rate of smoking for men has declined more sharply than the rate for women. Why? Some possible explanations are the availability of low-nicotine cigarettes to teen women, advertising that targets young women, people in ads look attractive and adventuresome, although smokers are at risk for gray, wrinkled skin. European Americans may be more susceptible to wrinkling than African American smokers, and men who smoke are at a high risk for impotence. Women's concern about weight. The women's rights movement. Women have a lower quitting rate than men. No single explanation has gained substantial support from research. Among those who smoke regularly in adolescence, 70% become regular smokers in adulthood. Most teen smokers believe they will no longer be smoking in 5 years. Although most adolescents would like to quit and believe it would be fairly easy to do so, only 16% of adolescents had quit when they were contacted 4 years later. 95% of regular smokers start before they are 20. Cigarette companies marketed to children. For example, the cartoon character Joe Camel. children were swayed before they were fully able to weigh evidence concerning their habit. A study of 895 urban adolescents assessed attitudes and beliefs about smoking and found they overestimated how many adults smoke and how many of their peers smoke. They also underestimated the extent to which others hold negative attitudes toward smoking. Many believed they were less likely than others to contract smoking-related illness. This is considered the optimistic bias. They also showed poor understanding of unpleasant consequences people experience when they try to quit. These misperceptions are most common for those who'd already begun to smoke, who had friends or family who smoked, or who intended to begin smoking in the future. Factors associated with smoking in adolescence. Peer influence is the most important factor in the beginning of smoking in adolescence. Adolescents are more likely to start smoking if they have parents who smoke, they have favorable image of a smoker, they are from low socioeconomic status, they feel social pressure to smoke, they are female, weight concerns, they are low-achieving students, they have external locus of control. Smoking is part of problem behavior syndrome. There's a strong correlation between smoking and drinking, illicit drug use, delinquent behaviors, and precocious sexual activity. Adolescent smokers tend to be rebellious, lower in achievement, and less involved in school sports. Other predictors of smoking. Education. The more years of school, the less likely they are to smoke. Smoking and illness or death. Smoking and cardiovascular disease or CVD. Today, CVD is the second largest cause of tobacco-related deaths. Cancer is the first. Smoking damages arteries and speeds formation of plaques, is related to formation of blood clots along artery walls, causes inflammation, changes lipid metabolism, and decreases availability of oxygen to the heart. Smoking and cancer. Cancer is the leading cause of smoking-related deaths. From 1950 to 1989, lung cancer deaths rose sharply, a trend that lagged about 20 years behind the increase in cigarette consumption. When people started smoking less in the mid-1960s, lung cancer deaths among men declined about 25 years later. Smoking and chronic lower respiratory disease. The two most deadly chronic lower respiratory diseases are emphysema and chronic bronchitis. These diseases are rare among non-smokers. The non-smokers who have these conditions tend to be exposed to smoking from a spouse. Other effects of smoking. Smoking is related to the recurrence of ulcers, periodontal disease, poorer balance, poorer cognitive functioning, and serious visual impairment, macular degeneration for men. For females, smoking is related to double the chance of developing ovarian cysts, decrease in bone density, increased chance of fertility problems, miscarriage, preterm and low birth weight in infants. Males who smoke are also more likely to have erective dysfunction. Synergistic effects of smoking. Smoking and cholesterol interact to produce higher rates of morbidity and mortality than would be expected from simply adding together these risks. Weight and smoking may also interact to increase mortality. Thin smokers were at an increased risk of mortality compared with average weight smokers. Reasons for this correlation are unclear. Stress and smoking. For men, nicotine can increase the magnitude of heart reactivity to stress. For women, smoking can reduce the heart rate but increase blood pressure responses, also an adverse reactivity pattern. Although type A and type B smokers do not differ in number of puffs taken or puff volume, type A smokers' inhalation duration is longer. The result is alveolar carbon monoxide level is higher. This difference may explain the correlation between type A and chronic heart disease, CHD for smokers. Smoking interacts synergistically with depression, such that a depressed person who smokes is at greater risk for cancer. Immune changes associated with depression interact with smoking to elevate white blood cell count and to produce decline in NK cell activity. NK cells detect and respond to early cancers.